Bismillah ar-Rahman ar-Rahim. Today I would like to continue the subject of AV canal defect. So I will talk today about the pre-anesthetic assessment, which is something that will be short, I believe. It is just about when you see a child, whether in the PICU or in the ward, for AV canal defect repair, or like redo repair of the valve if there is regurg, what you will think about. So the pre-anesthetic assessment will start first with the patient's age and weight. So the patient's age is important because if this child is presenting very early, like in the first months of life, that means there is an indication for that, which most probably will be ventricular failure and shock and low perfusion because of severe AV valve regurg. So this is about the age, and if this patient presents late, that means the possibility of high pulmonary vascular resistance is there, and I have to see and look if there is a cath lab done for this child and if there is a pulmonary vascular resistance is high. This is about the age. And about the weight, of course it is very important for pediatrics because of adjusting the dose, and the surgeon will ask about it, the perfusion will ask about it, so it is something very important to keep in your head. After that, I will see the cardiac lesion. Is it a partial AV canal, just atrial septal defect, or the complete AV canal, so atrial septal defect and ventricular septal defect? And also they may give a note about the VSD if it is restrictive or not. The next step will be the proposed surgery. Usually this is written very well in the GCC. GCC is like a meeting done by the surgeons, cardiologists, interventional anesthetists, and the PICU team as well, just to decide. They will see like a list of patients, 4 or 5 patients, and decide what we will do for each patient of them. This is a very, very nice thing to attend if you have the chance to do, and if not, and you are seeing that patient for a pre-anesthetic assessment, it is very, very useful to have a look in this GCC report because it will have most of the things that will affect the management. The next point is the redo, and everyone knows how much it is important to know if this patient is redo or not. So for a patient who had sternotomy before, so the possibility of injury to the heart or the major blood vessels when doing another sternotomy is high. So everyone should know about that. Blood should be ready, ice should be on the head, and pads for cardioversion or pacing should be on the patient at the time of induction anesthetic before starting the surgery. It is very useful to know how this patient presents. So if this patient presents with a very, very poor function with low perfusion manifestations in PICU or mechanically ventilated, or even not mechanically ventilated, but the systemic perfusion is low, this is a very sick patient, and I'm not expecting this patient to do great after doing the surgery. This patient will need some time in the PICU to recover, and this is a patient who may need ECMO after the surgery. This is a patient who may not be for fast tracking, so I will not be keen so much to do a block for this patient, for example. But if a patient who has partial AV canal, just ASD, or even ASD and restrictive VSD, but is doing well, not on oxygen, not on oxygen, there is no big issues with the feeding, so this patient I may think about fast tracking for this patient. So lots of decisions are taken by me and by everyone according to the presentation of the patient. I will also have a look and see if this patient has any other non-cardiac issues that may affect the management. For example, if this patient has a problem in the kidney, for example, UTI, or this patient has like borderline kidney function, I will expect that this patient will give the PQ hard times because the kidney function will be worse after the operation because of the cardiopulmonary bypass and blood transfusion and lots of challenges that the child will face during that period. If this patient has liver hit, if this patient has recent necrotizing enterocolitis, if this patient has any associated congenital anomalies in any other parts of his body, so this is really important to know about. So the echo is very, very important. It is our major tool of assessing the patient, and it's worth going through every step in the echo, every note in the echo, and see, because lots of these findings in the echo will affect the management. It will give me an idea about the patient, if this patient will be an easy patient or a difficult patient, if the intubation will be, if the induction of anesthesia will be stable, straightforward, or I may have troubles, if the coming of bypass will be easy or we may have troubles, is the stay in the intensive care will be fast tracking, or this patient may stay for week or weeks before recovery. So the most important points in the echo will be how much regurg in the AV valve, how is the function of the ventricles, if this patient is complete or transitional AV canal, is the VSD small or big, is it restrictive or non-restrictive, because this will be reflected on the pulmonary congestion and will be reflected on the early development of pulmonary hypertension. Also, I may look at if there is a note about the mural leaflet and see, because as we said before, if the left mural leaflet of the common AV canal is small, that means the mission of the surgeon to prepare this valve will be challenging, and this patient may end up with some residual regurg or some residual stenosis after coming off bypass. Also, the common AV valve, sometimes some chordae from the common AV valve cross the VSD from one side to another side. So when the surgeon wants to separate the ventricles by a patch, so these chordae will be in the way, so the surgeon may need to cut this chordae or reattach it again, which makes it a bit more reliable for regurgitation and the issues and the problems with the valves after the repair. Also, the imbalance, if this was an unbalanced AV canal defect, how big or how small is the other ventricle, the hypoplastic ventricle, is it a good ventricle that will manage after the separation, or it will give us hard times after. I also want to see if there is any other associated lesions in the patient. So a patient who came late, or a patient who had some episodes of cyanosis, or the patient who has recovery of his chest symptoms without a reasonable cause, so there will be a doubt that this patient has already developed pulmonary hypertension. So if I see a cath lab done to a patient like that, I need to see if the pulmonary vascular resistance is high or borderline or low, because this will give me an idea about the anesthetic management and about the post-operative management of this patient. If this patient will be a patient who is to the side of increased pulmonary vascular resistance, so my ventilation will change, my ventilation plan will change. I may think about nitric oxide, and also in the PQ, the weaning of ventilation, and also the incidence of pulmonary vascular crisis will be something that should be in mind. I will see the general condition of the child, his feeding, his gaining of weight, if he has mild or severe work of breathing, if he is on lots of diuretics or just managing without diuretics, is he room air or needs oxygen, is it just nasal cannula, or this patient needs high flow nasal cannula, because this is like the baseline of the child, and I will tell the PICU team after the surgery about his baseline, because most of the people, most of the management will be aiming towards getting him to at least his baseline. So it is a useful information to know how was the patient before the surgery. So as a routine, we look at the airway and exclude any allergy, and we see the medications. Most probably those patients will be on diuretics, and some of them may be on heart failure medications. This is a point. The other point will be the labs. We'll see like routine labs and see if there is any issue or any problem. I will carefully assess the electrolytes, because it may be deranged because of the high doses of diuretics the patient may be on. Also, I want to check if the cross match is ready or not, because this sometimes causes a bit of delay early in the morning in the while doing when we are to do the surgery. Okay, from the micro point of view, there is some routine micro tests that are done at these days. The COVID is routine, and also the MRSA is routine. And of importance, if this patient has recent chest infection, especially if this patient has like viral infection like respiratory syncytial virus or influenza virus, because these infections makes the weaning of ventilation after the operation a bit challenging. So I'm not expecting this patient to be easily extubated in the first night of his surgery. And also the anesthetic management and rapid desaturation and like decreased compliance of the lung with ventilation. So lots of things can be affected by the recent chest infection. Also the decision to do the surgery or not. For example, for a child who has recent respiratory syncytial virus infection, and this patient is for elective surgery, so we may decide to wait a bit until he recovers from this infection, because it makes every step of his management much difficult after. I want to see if this patient has IV access, because if there is a good IV access running, that means I can give some fluids for the child, so the child will not be fasting for a long time, which is a good thing. I will give IV induction, so this will be easier. I will not be worried about putting IV access to the child in the morning, especially if this patient has like poor ventricular function or like severe regurg, so a lesion that I'm expecting the child to collapse with the inhalation and induction of anesthetic, so the IV access will be very useful at this time. Also, I want to see if there is any precautions of using any of his blood vessels for the central line and the arterial line. For example, a previous surgery, he lost one of the arteries, he has injury to one of the femoral veins or arteries, so this is usually useful. So after doing that, I need to discuss the anesthesia plan with the family. So from the previous points, I will have a plan in my mind whether this child is a child in a good condition, who will tolerate pre-medications. If this patient doesn't have IV access, this patient can tolerate inhalation and induction. Is this patient for fast tracking, or this is a patient who will stay for long in PICU? So I will decide if I will do a block or not. And so all of these things need to be discussed with the family. So after my assessment I will be it will be clear in my mind what I'm going to do for this child in the morning. So I will discuss all these points with the family. So this is really useful to discuss every point of this with the family, and the family knows about our plan. So through it, the pre-medication is good. Midaz, for example, half milligram per kg, maximum 20 milligram. If the child doesn't have very high increased work of breathing, or problem with the ventilation, or problem with the function. IV induction if I have IV access, or if this child will not tolerate inhalation induction. Inhalation induction if I don't have IV access and the child can tolerate it. A block if this patient is for fast tracking. I will tell the family about the lines, because they will see the patient after recovery and they will find very, very big lines and the catheters coming from the neck, coming from the groin. So it is very useful to give the family an idea about what we're gonna do for this patient, and also the intubation and the possibility of using the TOE, because the TOE can possibly cause injury to the airway or injury to the esophagus. So it is better to tell them about that and to tell them how important it is for the surgery. I will go through the anesthetic risks for this patient. If this patient are redo, of course the bleeding will be the first thing to talk about. But in general, any child will need a blood transfusion because of the volume of the bypass tubing and machine. So it is very useful to tell them that this child will need a blood transfusion. Tell them about the possibility of any allergic reactions, about the possibility of any any injury to the airway or the blood vessels and to the esophagus because of the TOE. Also, I will tell them about the story of stopping the heart and encouraging the heart to come back after finishing the surgery, and how this can affect the heart muscle, and the heart may need medications to encourage the heart to work after the surgery. And for a patient who has poor RV function or severe RV regurg, or like a very big defects and or a very poor general condition before starting the surgery, I would mention the ECMO for the family, because so they will not be like surprised by this when the patient comes off bypass to ECMO and goes to the PICU on ECMO machine. And also I will give them an idea about what we are expecting to happen in the PICU. For a child who is in a very good general condition, I may tell them that there is a possibility to be extubated early in the first or second day. But for a patient with a poor general condition, poor RV function, unbalanced AV canal, severe regurg in the AV valve, so I will give them an idea that this patient may need some time to recover and to be slowly weaned off ventilation and hemodynamic support in the intensive care. And I will open the discussion and ask them if they have any questions or any concerns to be discussed. And I think that's all for the pre-anesthetic assessment. Thank you for listening. And I'm gonna continue the proper anesthetic management in the next presentation. Thank you.